Welcome. So we have Dr. Hoffman here today from Maine Medical Partners Pediatric Specialties, GI. And Dr. Hoffman board certified in pediatrics and GI. And he did his residency and fellowship at Children's Hospital, CHOP. And we're very fortunate to have him here today to talk about constipation.
Constipation.
Okay. Awesome.
All right. I'll start my microphone.
I talk pretty loud, so that's usually a problem. And I'm also very informal usually with how I do this kind of thing. So many people in this room have questions or thoughts or anything that comes up as I'm going. Please interrupt me if anybody who's out in the interwebs has any questions or comments that can get to me. Then feel free as well, for sure. Is the phone working okay, the way that it's meant to? Can you tell? Okay, perfect. I don't have any disclosures to tell you about. I always, just because we're sort of colleagues all working in the same place and I see each other, we see each other's patients, and you all like to know them, and I like to know who you are. I also, just another little introduction of kind of myself and where I've been and where I'm from. I grew up in Harpswell, so I'm a Mainer. It was always our hope that we'd come back to Maine when we were done with all of our training journey and everything like that, and it worked out. I went to Colby College, so I couldn't even leave because I like to see, and the football coach at the time, I played football there. I was a fullback. Was a great guy named Tom Austin, who is no longer the coach, but is still a great guy, and convinced me to stay. Then I went over to Dartmouth for med school, and then did residency and fellowship at CHOP. And while I was a fellow, I did a master's degree in health policy research at Penn, which is sort of like, you can think about that as a combination of kind of a master's in clinical epi and a public health kind of degree. So I have some statistics and research skills that I was like totally planning on using as like an academic person at CHOP for years to come. And then like there was an opportunity to come home, and I said, I guess I'll be a doctor. I'm not gonna do this academic thing. So we moved back to Freeport last summer. So that's kind of my since I left my nest. So constipation might make everybody in the room feel like that, like kind of sleepy and bored. Might make everybody feel that. That's my brand new son, James. He's like 9 years old now, and doing well. But certainly just having him around makes me feel like both of those things. But actually, constipation is super common and super important for everybody. It's like there are various prevalence estimates, but 90%, probably more than that of our kids are going to deal with some constipation at some point in time. So it's like a massive percentage of our referrals, and actually it's something that we'd sort of like to have fewer of, and hopefully help some of these kids kind of stay in their medical homes a little bit more. So this is kind of a slide just as a little bit of context before I start rambling about the way that I do things and some other stuff. This is a Cochrane review about the use of laxative medications in pediatrics from just a year ago. And just in the background introduction, they make two really important comments: that there's widespread use of osmotic and stimulant laxative use in pediatrics, and there's a paucity of high-quality evidence to support this practice. So I went to review all that. I didn't find any more evidence when they reviewed it all. So the bottom line is that a lot of constipation management, certainly the way that I learned it, the way that I do it, is a style. It's based on NASPGHAN guidelines. NASPGHAN is the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, and that's the society that we all belong to. But those guidelines are largely expert opinion. They're not based on clinical trials for the most part. So there's a reason that the colon is kind of shaped like a question mark. It's all just we kind of, there's a lot of art in what we do. And it's important that everybody, and I think including families, I'm very upfront with them, and I tell them that's true. Like, this is the way that I tend to approach things, and it'd be nice if we had a little bit more data. But the art. So with that, I first really want to just review the definition of constipation, because the way that I think and sort of act, I try to be really rigorous, at least myself, and consistent, internally consistent with the way that I define things and approach things. And so for me, definitions and being really clear with myself about what I'm treating and what I think is going on is important. So I like to start with some definitions there. Then I just review some of the sort of pathophysiology of constipation with encopresis, which won't really be anything new for you guys probably, but we'll sort of taught it the way that I teach families and the way that I talk to them, and maybe there'll be a pearl in there that some additional talking points in your armamentarium. And then you again sort of the importance of the clean out within that context when you meet a child who's constipated and has soiling. We'll talk about some red flags that certainly warrant further evaluation in constipation. There are kids out there who have these and who we see, so it's definitely important that you know about these and that you get in touch with us and send them our way when you see them. And then I purposely didn't make this very long because I'm hoping that we'll have a little bit of time to bring up cases or questions or whatever, because it's such a common thing. I'm sure everybody has those. So functional constipation defined, like every kind of functional GI disorder, there are these things called the Rome criteria. They exist for functional gastrointestinal disease in adults. They exist for functional gastrointestinal disease in children. The NASPGHAN guidelines suggest that this is the way that we should diagnose and define functional constipation in pediatrics. So it's no great surprise because the same people who wrote the Rome criteria wrote the guidelines. So it is what it is, but it's a starting point. So you have to have 2 or more of those bullet points for a minimum of a month and not otherwise meet criteria for irritable bowel syndrome, which we will talk about if people have questions at the end and kind of want to. So those things are 2 or fewer stools per week in the toilet in a kid who should otherwise be sort of toilet trained and have modes on the toilet. An episode of fecal incontinence a week, retentive posturing, or that sort of hiding in the corner stool withholding behavior, having painful or hard bowel movements, being a large fecal mass in the rectum at the time of your physical examination when you're talking about this with the kid, or you have large diameter stools that can obstruct the toilet. So again, 2 of those. It's terribly hard to meet that definition for a lot of the kids who we meet probably. But it's kind of a, I don't know. Yes. This kind of, the like, I'm just not gonna do it. I'm just not gonna do it. Kind of holding it in, kind of thing. There's a guy named Alex Flores, is one of the motility gastroenterologists at Boston Children's, and he calls those people the duty dancers who kind of do this thing. So duty dancing is retentive posturing. Comes out kind of blurry again, just to reiterate this point from the NASPGHAN guidelines that we recommend room 3 criteria for the definition of functional constipation, and that the diagnosis of functional constipation really should be based on history and physical examination. And all those 9s mean that all the voting members of the people who were writing guidelines agreed very strongly with that statement. So I would like to just sort of point, because this is kind of one of my things. We all have our things. Notably absent from the definition is a 1-view abdominal X-ray that's read to have like a moderate stool burden. So my personal take is that, and there's data to suggest this, where there's a lot of data otherwise, that it's really not necessary to do that. And the way that I put it for people is, and for residents and people who ask, is that if you are curious about whether the child might be constipated or not, but you're sure, and you get an X-ray, and you see poop in the X-ray, like, they're going to be constipated because that's what you thought you were going to find. So I think you can try this without, and then I'll get into a little bit about. So people in the room are probably a little bit familiar with the idea of receiver operated curves for various diagnostic tests. The receiver operated curve it's a statistic that sort of tells you about how well a diagnostic test is able to differentiate between 2 conditions. And when we talk about constipation as a condition, in this study, that condition is defined by those Rome criteria that we talked about. So what they did was they took a big number of kids who had abdominal x-rays. They compared 3 different radiologic scoring systems for defining a stool burden on those x-rays, and whether or not the x-ray diagnosis was constipation. And they compared that to the clinical diagnosis of constipation, which, you know, for better or for worse, is the gold standard at this point. And the ROC curve, like a perfectly sensitive and specific test, the line kind of goes like that across. And a test that's like a coin flip goes that kind of. And see, this is like a little bit better than a coin flip 7. So most people in biostatistics will talk about 0.7 as the time when a test starts to something that could potentially be meaningful. A little bit of context, a rapid strep has an area under the curve of 0.5, so pretty good at discriminating whether or not there's strep there. And this is another point of context. If you just check somebody's platelets and elevated, like that has a higher area under the curve for diagnosis of inflammatory bowel disease than a 1V abdominal x-ray does for constipation. So the point is it's really a diagnosis that you can make clinically, and you should feel confident about making it clinically. The other thing that's really interesting about this study is that for all of the scoring systems, the inter-observer variability for the way that different radiologists scored the same films was really different. So if you give the same picture to different people, they see totally different things. And so x-rays may not be as helpful as we wish. So am I saying that there's really no role for x-ray here? No. I mean, clearly there's a time when it makes sense, when you maybe need to add some objective evidence to a case that you're making to a parent, when you need a way to evaluate for really significant rectal stool burden when it's just not possible in your physical exam in the office, something like that. So of course there are going to be roles, but I think the really point that I make with this is that functional abdominal pain and IBS are also really common. So if a child who just has abdominal pain and you're kind of looking for that, and an x-ray looks like they might be constipated, it's not unreasonable to try to see if they get better if you treat their constipation, for sure. But I find I meet a lot of frustrated families who have done cleanouts after cleanouts after cleanouts, and the stools are better, and the stools are softer and more regular than they used to be, or maybe are no different than they used to be. But the kid's abdominal pain is not any different, and nobody has introduced the concept of other diagnostic possibilities that might explain their pain to them before. So I think when you know, constipation is really a clinical diagnosis, but if shoe doesn't fit based on the response to therapy, I think we should all be open to sort of thinking differently about what the diagnosis might be. So that's my sort of pet 10 minutes on x-rays. So I'm going to approach the next part is with a couple of cases that are kind of fresh in the last couple of months from clinic to kind of illustrate some of the other points, and then we can see about time at the end. So this is a boy who shouldn't probably be so different from all patients who you guys see. 5.5-year-old little guy, developmentally normal until he came with this chief complaint of fecal soiling. We'll go all the way back. He was breastfed in infancy, passed meconium, had soft stools all through his infancy, and was successfully toilet trained kind of just after age 3, with daily bowel movements in the toilet without any trouble, totally kind of urine as well. 1 year ago, the family moved from away to southern Maine, and shortly thereafter, he started having stool accidents with about a weekly stool on the toilet, but poops underwear multiple times per day, every day otherwise. Totally urine still, has normal lower extremity strength and tone, no issues there. And on his pediatrician's advice, his parents gave him polyethylene glycol or Miralax for a week, but the soiling worsened, so they stopped it. And then he came to me some weeks later on nothing and in that same kind of condition, which is not dangerous, but is very distressing for the family, for this boy who totally toilet trained at one point in time. So kind of what's going on here? And again, just to illustrate, like x-rays have a role. I use them sometimes. That's a marker study. And what I do with a marker study is have kids take a little SITS marker pill and then 5 days later get an x-ray. And what you're seeing right here is in a child with fungal fecal retention, all of those markers 5 days later are still in the and they're all kind of clumped together right in the rectum right there in a big rectal stool mass. This child's not evacuating his rectum on a regular basis, and that functional fecal retention, which in this case may have been brought on by stressors related to moving or something else, but that was my sort of working diagnosis for him, kind of leads to impaction, and that chronic impaction leads to one of my favorite words in medicine, a megarectum, which results in the soiling that we see going on for this kid. So just not pooping enough, mostly because he probably doesn't want to, is what's kind of put him in this spot. So this is kind of the way that I think about it and talk about it with families. And this is what makes treating kids like this hard, is that by the time they get to the point where they've had this chronic fecal retention and megarectum, there are two things that, two big physiologic problems that have happened. One is that they have altered conscious rectal sensitivity thresholds, and the second is altered defecation dynamics. So those are two phrases that I wasn't quite sure what they meant, and were drilled into me over and over again by one of my mentors in Philadelphia. But you know, he's absolutely right, and it really is helpful to explain to parents as if the rectum doesn't tell your child to poop anymore after it gets stretched out like that. So even if he decided that tomorrow I'm going to do this, I'm going to go back to being toilet trained, I'm not going to withhold stool anymore, I'm going to do it. He's going to have a hard time because his body's not going to tell him to poop the way that it used to. And the second is that big stretched out balloon rectum can't push as effectively to push the poop out. So two real physiologic disadvantages to overcome if and when he and his family are ready to get better, if and when they're ready, because there's just a massive behavioral component to this, as we all know. But there's a real fight there. So you've got a kid who's soiling most days of the week, doesn't need to have bowel movement anymore. They get relaxed for a week, and the soil worse, so they stopped. So that's kind of the condition that our poor little dude is in. So talk about it when I talk about moving forward and making a plan to get kids like this. I talk about it as if I'm addressing those two underlying problems for the family. The first is altered conscious rectal sensitivity threshold, and the fact that the kid's not going to have a signal, not going to feel it when they need to go to the bathroom. And that's really what you're addressing by setting up a regimented, structured toilet sitting program for them when they leave your office. You tell them that they're just, you know, we're not going to expect Johnny to know when he has to poop. So he has to give his body the opportunity to go to the bathroom, and we need to teach him how to push, and that's another area of interest where things like biofeedback and pelvic floor physical therapy may have a role depending on the child. But at least getting them to the toilet. And if getting to the toilet is a problem, it really is, you know, it's really important to start small, start slow, and just get them back into the bathroom. You know, if he's so scared that it's going to hurt, like just in the bathroom, sticker chart, good job, you're here, and you just slowly kind of have to work that behavioral piece back up. That's what you're fighting. You know, you're fighting that lack of sensitivity by setting up a structured toilet sitting regimen. Second, altered defecation dynamics is really what you're approaching with laxative therapy, which is absolutely going to be necessary for kids like this who end up in this situation. There are two kind of categories of laxatives. There are osmotic laxatives and there are stimulant laxatives. The PEG and lactulose. PEG, Miralax, is your sort of first line per NASPGHAN guidelines. And lactulose also works, though. It works pretty well. And that allows stool to stay soft, so that rectum can, hopefully as a child is evacuating more frequently over time, shrink back down and not be stuck in a big distended state around hard stool. And then stimulant laxatives that help with the squeeze and the push of the rectum. So those two really approach the altered defecation dynamics. I will say stimulant laxatives, their stimulation also increases sensation. So that sort of falls under problem number one too. But I've found that explaining that sort of down the physiology and telling parents that this is what we're doing to get to these two things. Certainly not every parent bites on that, but it's been very helpful for me over time. But first, before you get to that point, it's just tremendously important, as you all know, that clean out is going to be really important, because part of the physiology of that soiling is impaction, and so they're impacted by definition. And in this little guy's case, as in the case of so many kids, starting kind of a daily dose of Miralax, there's still a big rectal stool impaction, and Miralax as an osmotic agent just brings more loose stool down, and without removing that impaction, the soiling gets worse almost every single time. And parents get discouraged, and they stop, or they don't believe you when you tell them that they need it again, and it becomes difficult. So cleaning them out is important. There are 3 options for that. So oral clean outs is what we do most of the time. In office, we typically do 5 grams per kilogram of Miralax, as well as a stimulant laxative. Bisacodyl is the strongest stimulant laxative. I use that more than I use Senna. It comes in pills, so you can't really get a liquid for little kids to take, but not shy with it. Or in the clean out phase or chronically. A lot of families will raise questions or concern that laxatives can lead to tolerance and dependence over time. There's actually a great deal of science that backs up that concern, and my point to them is always that for a child who's soiling themselves on a daily basis, I think the benefit outweighs the risk, and you can always wean them, but they're safe and they're really effective for kids who really truly have rectal dysmotility by the time they come to you with this problem. But anyway, 5 per kilo of Miralax plus a stimulant laxative as an oral clean out. Rectal enemas are actually there's less incontinence during the clean phase. That's been studied if you clean kids out with enemas. But if it's a child whose constipation is rooted in anxiety around the toilet, anxiety around defecation, you may end up doing more behavioral harm by cleaning them out with enemas. So you really have to kind of read the child and the family. Certainly there are families and children where that makes sense to do, and then there are families where it doesn't. And you're not, neither way is right or wrong. And then in really extreme cases, but they happen, manual disimpaction, where you meet a child who you just examine their abdomen and it just feels like there's a big hard stale loaf of bread kind of around their umbilicus, and there's just no way you're going to get that out with medicine. So they have to be disimpacted, and we do that. I do a disimpaction. I usually admit them to the hospital afterwards and place an NG tube and just flush everything out with Go Lightly before I start, and just make sure that I'm really totally starting from scratch. But so once you've disimpacted, then you can kind of move on to the daily therapy. And here's kind of just the summary of the NASPGHAN guidelines. I think these are the important things to keep in mind for your maintenance therapy of constipation. Again, the idea of demystification, explanation, guidance for toilet training, that's a recommendation, although it's pretty nebulous. Like, what does that mean? To me, that means the structured toilet piece. The idea that the kids are going to sit on the toilet in a position that makes sense. And if you should watch the squatty potty video on YouTube. So you really should coach kids and families into getting into that position as much as possible. So sitting on the toilet, they've got something under their feet so that their knees are a little bit up above their waistline. And then it's not sitting for I don't usually have people sit more than 5 minutes or so of really good work time, like not sitting with a book or an iPad or anything, but really good work time where they either have a balloon that they're blowing up to increase their intra-abdominal pressure and stimulate Valsalva, or a pinwheel works really nicely, but doing something active to increase their intra-abdominal pressure and really work to have a bowel movement. The second physiologic part of having a bowel movement is learning to relax your sphincter muscle, and that turns out to be a really tremendously difficult thing to teach somebody how to do. There's biofeedback, there is pelvic floor physical therapy, but I usually just practice with the hope that teaching them how to increase their intra-abdominal pressure is going to help with things eventually, and eventually they're gonna relax that muscle by accident, and things are going to kind of come into harmony. So structured toilet sitting. Clean out was about the NASPGHAN guideline recommendation is Miralax, half a gram per kilo per day, about, lactulose, we talked about second line. And then the guideline says other therapies can be considered. I already told you there isn't really good, strong clinical trial evidence about the use of stimulant laxatives or any laxative. Anecdotally, I use, in children who come to me soiling, I have a pretty low threshold to have them on a stimulant laxative chronically after that, because I know that dysmotility is going to be a factor going forward. Not every kid, needs that, but I start most of them on dual therapy with an osmotic laxative and a stimulant laxative after I clean them out. And then if things go really well over the course of a couple of weeks, I quickly wean off the stimulant. But there's no, like I said, the guidelines just say that really the guideline is just that other therapies can be considered. I learned my practice from a guy named Tim Boyle, who's the motility expert at CHOP, and that's the way he practices. And that's, unfortunately, how constipation in gastroenterology is. It's just handed down from mentor to mentee. So, and then really, really important, and the thing that I think parents struggle with the most, is that it's pretty common that you can get a kid better quickly. Like, you can clean them out and start them on a regimen, and they do great for like 4 days. And it's really, really important when you meet them and you start doing this work that they understand that we really intend them to continue their maintenance therapy for at least a couple of months. And they should be in a place where they're not having soiling and they're having, I aim for 7 to 10 bowel movements a week on the toilet every day for a month before I'm really going to start weaning off their osmotic laxative. And for some kids that's 6 weeks, and for some kids that's 4 months, and that's okay. Setbacks are common. I tell people that I want to hear about it as soon as Johnny starts soiling again, so that we can act on it, get him kind of cleaned out again, and start over, and not let things build up for a week. The amount of response that I get to that recommendation varies by family, as you'd expect. I don't know how long that's been on the floor, but hopefully loud enough. That's really my practice. I really try not to rock the boat for a good long time once things are stable. And I tell families that up front that when I start these medicines, I really intend them to be used for a while. And the behavioral part too, like really, you need to stay on that. That's where programs like our Potty University program are sometimes helpful. I'm not going to say that that's a perfect program, but it's for the right family. Just reinforces that stuff. So in that case, 5-year-old after normal toilet training develops constipation and soiling. Those get impacted by definition. That's important to just that little phrase in your mind. They're impacted by definition when you meet them in their soiling. So you need to be disimpacted, and then they could be started on daily laxative therapy and daily structured toilet sitting. And the appropriate reward system is different for kid in every family, but the old sticker calendar with just for the Disney movie of the month are pretty good, I find. That's our son Max, looking cool, and that's actually like as there's nothing humorous about the thing that I just described to you, except that like when it hits and the kid gets better, like there's not that much else in my job that's as good as that actually. Like Crohn's disease doesn't get better, like they're still sick, and disease doesn't get better. You can take a kid who's literally pooping their pants every day to not pooping their pants ever, like that's pretty good. So now we'll hit on a couple of the red flags, some of the things that weren't going on for this kid in this case. He didn't have constipation early in life. He didn't have any delayed passage of meconium. There wasn't any worry there. This kid really wasn't having persistent or refractory abdominal pain as part of his presentation. No blood in the stool. Wasn't having fevers. Was thrive. There was no real vomiting at all or abdominal distension. Distension, I will say, I'll just stop on that one for a second. That's one of my most important indicators, especially as I'm meeting a baby. Like if you have a baby or a child who you examine, I find that parents have a very difficult time like knowing what we're talking about when we say distension. I'm not talking about sort of soft protuberance. I really mean like the belly's firm to push on. And you meet a kid who really feels distended. To me, that has a much higher positive predictor value for an actual distal obstructive process like Hirschsprung's disease or an anorectal malformation, something like that. That's definitely an important red flag for kids. Anal fistula or some abnormal anatomy of the anal area when you do your rectal exam. Those are the suggested red flags by the NASPGHAN guidelines, and I think that that's a pretty list. I add to the list a really true lack of response to a good, well-done laxative and behavioral regimen. I always, when I meet a kid who has constipation, I'm not usually, oftentimes it's been done already, which isn't necessarily inappropriate, but I usually don't do investigations when I first meet them for other things, which we'll talk about in a minute. But if you really are convinced that the family was doing what you asked of them and nothing really changed for the child, then I think that's a red flag that warrants a little bit more thought. I'll just reference quickly our kind of referral guideline for constipation. As you probably know, we have referral guidelines in all of pediatric specialty care over there. They're online on our website. You can access them. They're not nothing's perfect, but they are pretty good with regard to a little bit of guidance, and especially to kids who we don't mind or would encourage you, in fact, to call us about if you have one of them in front of you. For this kid, the case that we just talked through kind of falls into this low risk category. Soiling without really a trial of a clean out, infrequent stools, holding behavior, and our guideline says that that guy should be cleaned out and started on the regimen that we just kind of talked about. So that is one of the interesting ones in my early career here. Was a 7-month-old boy who his parents noted to have really significant discomfort and straining with bowel movements. And that's not so unusual for an infant to have some dyschezia normally. We expect that. We counsel parents that that's a normal phenomenon. And so that was inappropriately, I would say, done for this family over time. This guy also had normal stools after birth, passed meconium normally, and there was nothing unusual about PD soft breastfed stools in the first 3 months of life for this kid. Over 4 months from that time to when I met him, he sort of developed this phenomenon where he was really only passing, his mom described it as the same thing every week. He would have his period where he just passed these 3 monster boulder hard stools. And once a week, nothing else ever came out of his bottom. Just was there was blood and just tremendous discomfort and straining. Despite normal growth, eating appropriately, not vomiting, not distended, not really he had some soft protuberance and definitely had palpable stool in his abdomen, but he wasn't firmly distended. This X-ray that he had before he came to see me, and that's what I'm talking. That's sort of what the picture of a child who when you dad is like, okay, that probably is going to be disimpacted. That's not going to come out unless we do something to take it out. And I think it also nicely illustrates the fact for everybody who remembers their anatomy or has trouble remembering it, like I do sometimes, is the sigmoid colon is totally not attached to anything, and it kind of comes up, and then it does this big turn like that before it comes back down, and you get the colon coming up this way. So the sigmoid colon coming up like this, and it's just massively full of stool. So that's normal X-ray for a 7-month-old. So for this guy, we've got pretty significant constipation in the first year of life, and a palpable stool mass and almost palpable stool on an X-ray. And so for that's a red flag. I would say for infants, I don't feel palpable stool on an infant very often. Like they sometimes have hard stool and sometimes fit the definition of functional constipation in infancy, but those kids rarely have palpable stool masses, I would say. So he's got red flag symptoms, and you have to think about the possibility of kind of mechanical obstruction rather than something functional with the early onset of symptoms and the really significant palpable stool. So in this age group, that differential for me is actually sort of the same as an older kid. Lead, electrolyte abnormalities for kids who have disease or other reasons to have those, thyroid disease, celiac disease, Hirschsprung's, and then other various kinds of anatomic obstructive etiologies of the rectum and anus. So I worked at a little bit. He had a normal lead level, normal electrolytes, normal TSH, normal celiac screen, which in a 7-month-old you really have to include the deaminated gliadin peptides because the TTG is not going to be as sensitive in a kid this age. And so then there I went to evaluate the anatomic things. The barium enema that looked like that, and the radiologist sort of read it as, and on a barium enema we're looking for Crohn's disease primarily, and you're really looking for a transition zone. And the radiologist, who she and I looked at the film a lot together, sort of, well, maybe this is a transition zone as we're coming down, and maybe the ganglion cells didn't migrate from there down to this part. He said, all right, let's go ahead and look harder for Hirschsprung's disease, since the child, isn't anything differently on lactulose, and set him up for a rectal suction biopsy, which the surgeons do for us most of the time. They went to meet Chris Turner, who brought him to the operating room, and so that's the anus. And there was something about that didn't look totally normal to me when I met him, but not so not so abnormal as sure. And the radiologist was sort of the same thing when they did the BE. It was like, it's not totally normal, but there's an opening and it's there. And even Chris, in his exam with them, was like, it's not totally normal, but it's there. Kind of small. You don't see the sort of normal anal furrowing that's there for most kids. So as part of setting up for a suction biopsy, he did a anesthesia, which in this age group for those kids includes bringing the little electrostimulator back to the OR. And when he stimulated down the perineum, very clearly there's a video that I have, but didn't really fit into this PowerPoint size-wise well with email and such. When you stimulated this part of the perineum, you get this very nice cyclical contraction right there. So this is imperforate anus with a fistula, and so this child had that repaired shortly thereafter, and actually done really, really well. But that's, it's a good case of an infant with the unusual bowel pattern and palpable stool who should raise your index of suspicion. So that's Max just holding up a red flag because A, it's raining out and he's mad, he can't go play with his tractor, and B, because this had early onset of symptoms and palpable stool mass. So that was about all I was going to talk about. Just remember that we said that functional constipation is really a clinical diagnosis. The Rome criteria and NASPGHAN guidelines, I would definitely, we all see this all the time. It's well worth having that on your desktop. You can open up, look at, refer to when questions come up, because there's a lot of good, again, it's mostly expert opinion, but there's a lot of good guidance in there about the way that we think about and manage this. Not only for constipation, certainly if you start treating a child for constipation and it's not working the way that you thought it might, continuing to do multiple cleanouts, maybe a frustrating experience for the family, and maybe make it harder to pull them to whatever the ultimate diagnosis for their pain is. Retentive soiling occurs because of these chronic changes in rectal sensitivity threshold and defecation dynamics. And remember those two phrases and kind of teach your families that way. I think that's been helpful. Children with constipation soiling are impacted by definition. So impacted by definition, they need to be cleaned out before we start therapy. And don't be afraid to call or refer, get in touch if you see kids where there are red flags that have your attention. And there's just one more picture of Max, James, and Sarah, who many of you know as one of the hospitalists at Barbara Bush and also a pediatric sports medicine physician for Maine Medical Partners. So hopefully a chance to have some questions or comments. Happy to comments as well are welcome if you found other things that are helpful to learn from you as well. So,
Noah?
Yeah.
I'm down in South Portland. It's Andrew Tenenbaum. Great talk. Thank you. We don't have to make any more referrals to now. So I'm wondering what role, if any, you recommend for dietary changes for constipation?
Great question. You asked about dietary changes for constipation. I think I'm in the phase where I know better than, I, as well as most parents right now, that it's to alter the diet of a toddler. but I recommend fiber. I recommend a normal amount of fiber for a child, age plus 5 grams about. That's not a supranormal amount. That's just a normal amount of fiber. If they're not getting that amount, I do say that it's okay to do a fiber supplement, Metamucil or some other form of psyllium that they can pick up at the store. But fiber's tricky because if you have a kid who's not getting enough fluid as well, the fiber can really just kind of turn into a brick. So you can't do fiber without making sure that they're adequately hydrated as well. I make that part of my guidance as well. A dietary thing that's helpful for some. There is actually some evidence, some observational evidence that restricting cow's milk in toddlers is effective for functional constipation in some. So again, when you have a kid who you start on therapy who's relatively refractory, I will restrict cow's milk if the family is up for it. I think the 2 dietary kind of interventions that I do, there isn't much role for probiotics in this population. There's not much data to support it, and I worry for some families that buying probiotics is going to keep them from putting other food on the table. So I don't usually recommend probiotics.
Thanks.
Yeah, I mean, I think about prune juice in general as just another form of kind of osmotic laxative. So it certainly can have a role. Juices like prune juice and apple juice are really high in FODMAPs, which are the small molecules that go through our GI tracts without being absorbed. So they sort of act like molecules that way. I have found when I've and maybe this is just because they've already been through those kinds of interventions by the time I'm meeting them. I generally prefer, again, because I think most of the constipation I end up taking care of, because succeeding constipation requires attention to the regimen that you put a child on. Prescribing that regimen is important to me in my practice. I find it easier to prescribe osmotic agent than to use juice. But it certainly has its role. I mean, if you have an infant or a toddler who has, we didn't talk about kids who fit criteria who aren't soiling, right? There are certainly kids who have infrequent painful bowel movements who fit Rome criteria for functional constipation. Those kids, I think, are absolutely appropriate for an osmotic laxative alone without a stimulant. And if prune juice or others work in that setting, again in a regimented way, because the problem of altered sensation and altered defecation dynamics is still there, even if they're not soiling. So they're going to need some therapy in a regimented way for a period of time for that to improve. I think it's fine.
Had a lot of scary Miralax
Yeah.
input.
So is that it's very hard for me to argue with a family who tells me that something changed when they started giving their child something. So I don't argue with them about that. And I think that it's I can't tell you with 100% certainty that there's nothing to it. I say for people who are asking the question, and I'm talking about using Miralax or other laxatives, because other laxatives have been implicated as well. I mean, every laxative has been sort of did at in one another. Is that when you take a child who is in a behavioral place where they really want to do everything possible not to poop, and you give them something that's going to make them harder for them not to poop, like that's going to be a very stressful experience for them, and that's very likely playing into any behavioral change that we see as well. Even with that, families, I just do my best to say if it's a family who asks the question, it really is true. Like there's no clinical trial evidence that this is a real problem or that there's a signal more relaxed than anything else. People are still super opposed to it, and I use lactulose if that, and that's fine. It still works. I mean, lactulose works really well. It's a good osmotic agent. It causes more gas, causes more cramps, but it works. So. it's a tough thing. CHOP said they were going to study that problem and got some money to study it, and I haven't heard much about that. I don't know where that stands. So.
With the clean, you recommend 1.5 grams per kilo per day?
I do like a one-shot go clean out, so 5 grams per kilo of Miralax and in a big volume of Gatorade, and planning to spend the day going to the bathroom and just be done with it. I don't usually do 5 per kilo in a one. I'm not a big. I found that like doing like a 3 caps of Miralax a day dose for a family for 3 days or a week or something to get things moving. Like oftentimes people tell me that they end up soiling more when they went on that and they get frustrated by it. So I try to say, look, it's been going on for a long time. Let's wait until there's a day when you can do this. There's nothing dangerous about that, and we'll dedicate that day to doing a big clean out. I have them take the stimulant laxative kind of first thing in the morning, and then them do, and a couple hours later, I have them start drinking 5 grams per kilo of Miralax in some volume for one day. And to do it a second day. Like some days, if the first day is not effective, but it's usually effective. It's kind of like that's essentially the same thing as our colonoscopy preps. So, which is what you'd hope to start with, right? So. Cool. Good. All right.